Hello and welcome to this presentation in which I will explain the data flow in which data collected in the field will flow upwards to the national level and the processes we will use to collect and digitize and store this information using our DHIS2 electronic data repository. So in this presentation I will use a very simple structure. First, I will shortly address why do we monitor and evaluate. Secondly, I will touch base on what we want to capture using our mail systems. And thirdly, I'll give a very brief intro in how this will be done in the Ascent program. So first, why do we monitor? We monitor performance and it helps us to set realistic targets. It helps us to look at what we set out to do and then to make decisions which are relevant and attainable and measurable within the project. Secondly, we monitor and evaluate to learn from our operations. Throughout the delivery of Ascent, there will be changes in how we do things and how effective we've been on delivering our targets. Therefore, these learnings will be collected and taken forward in order to optimize programming in the future. Which leads to the third point, which is decision support. So using the monitoring and evaluation information which we collect, we hope to make better decisions and planning for future iterations of the program and more targeted and more effective and efficient resource allocation with regard to funds as well as human resources. And fourthly, our monitoring and evaluation system allows us to be accountable. On one hand, to be accountable towards our donor and showing what we've done and providing evidence of our delivery, but also towards other partners in showing governments and other international partners on how Ascent has worked to move the NTD agenda forward. So now we know why we monitor. I want to touch base on what we want to monitor. This slide is showing the diagram displaying the theory of change which we use in Ascent Lot 1. So from top to bottom you will see the vision of the program, the impact we're trying to attain, going down to the short and long-term outcomes and going further down into the different types of outputs we will try to reach through our support. Now all the activities outputs are categorized into 4 pathways of change, which are shown in the bottom. The first one is the knowledge pathway. So this is all our evidence generating exercises, including the disease-specific assessments, but also research projects. In the middle, there's a big piece of the system and governance pathway, which is all the health system strengthening support, which we provide through Ascent. And then on the right-hand side, you will see the preventive pathway, for mostly being our BCC activities and MDA. And finally, the fourth pathway, which is the clinical pathway, which entails all the MNDP activities in clinical care. So you'll see for each of the pathways, there's quite a number of different outputs which we were working on. So each of the activities which are supported through Ascent, being trainings, being MDAs, being supported facilities or policy and procedure development, fall in one of these output categories as shown here. So I'll try to simplify that a bit more for each of the 4 pathways which are displayed on this slide. So on this slide you see the 4 pathways once again. From left to right, the knowledge pathway, the systems and governance pathway, preventive pathway, and the clinical pathway. Now, if we reorder these, you will see that we used activity-based reporting for each of these pathways. So again, for the knowledge, it will be mapping, DSAs, and beneficiary feedback. For the system and government pathways, we have activities based on policy development, training of staff at ministry, but also district level. System support, such as health information system strengthening or strengthening the supply chain, as well as partnership building. So this is working with international and national partners in countries to make an intersectoral approach to NTD control. In the preventive pathway, as said, we have the mass drug administration campaigns as well as the behavioral change communications to support the delivery of MDA. And finally, we have the MNDP clinical care, the behavioral change communications for MNDP, as well as visual leishmaniasis diagnosis and treatment. So how are the data collected and processed in Ascent? This slide shows a generic picture of how an MDA would report its data throughout the chain, starting on the top from community or school level implementation of the MDA, going down through health facilities, through to implementation units and the national office of either an implementing partner or Ministry of Health. So for each of these levels, you will see the different types of data management activities or processes which happen at that level of the data flow chain. So all the way at the top in the community level or in a school where MDA treatments are actually given, the treatments will be recorded. So these are the tally sheets which we use to score how many people actually have taken the preventive chemotherapy pills. Secondly, after the MDA has been completed, there will be a round of supervision coverage assessments. So this is visiting some of the households or some of the schools again and inquiring or asking people whether they actually have taken the drugs, yes or no, or what might have been the reason for not taking the drugs. Now these data flow upwards through a health facility where they're aggregated. So there's an aggregation of treatment results as well as the aggregation of the supervision coverage to results per facility. Here we also record the supply chain drug stock counts, which are not available at community level. This will be first recorded at the health facility level. Now all these data again are submitted to the implementation unit, typically being a district office, where they again aggregated per IU. This is for both the treatment results, the supply chain result, as well as the drug chain stock counts. Now the aggregated numbers, which were compiled at a implementation unit, are then sent to a national office where they're compiled into a single database. So we have a compilation of all the IU treatment results per IU available at national level. The same accounts for the supervision coverage results and the supply chain stock counts. What's added at national level is the recording of the training report. So if there's a training of CDDs or supervisors happening at the national level, the inputs and results of these will be recorded at the national level. So here you should think of the number of people trained, disaggregated by gender, but also the pre and post test results of that training, as well as the perceived quality of that training. So both the national training reports, but also the recording of beneficiary feedback will happen at the national level. Now, all these data elements, the treatment results, supervision coverage results, drug counts, the supply chain counts, and the feedback are then entered from a national office by an implementing partner or ministry into our Ascent DHS2 system, which can be found on ntddata.org. So this is the step where we actually capture all this information in our repository. So let's take an example of different forms you will find in the DHS2 and how they will report it. Here on the bottom side, you see time from the start of an intervention to the end of the intervention. So it all starts with the IU level data. So what is the current status of endemicity of a single disease, for example, lymphatic filariasis, or each IU? What's the population living in that IU? What's the endemicity of LF in that IU? And how far are we in the progress of the control program? So how many rounds of MDA, for example, have been completed? These information are available and updated by the global MEL team and will be included in the TOR. So this is a task which is performed by the global team. And if there's any changes in endemicity status, change will also be made by the global team. So next, once an intervention starts, there will likely be the training results. This can be the training information itself. So where did it happen? How many people were enrolled? What type of training were given? How many men? How many women? Etc. There will be the training information, the participant information, but also the training results and the participant feedback. Following the training, the next data piece which we expect, the next form we expect to be completed are the MDA results. So these are our planned treatments, so how much did we set out to do, and then how much did we actually deliver, so what were the outcomes of the MDA activity, as well as the supervision coverage tool results. So the revisit by supervisors to specific households to measure the coverage or uptake of the MDA. Then finally, after MDA, all the drug counts, so the stocks before and after delivery of MDA are reported. So these can be drug stocks, but also clinical inventory. So all these different data forms will be reported based on a contract. So if there's a contract which spans 5 IUs, there will be 1 training form nationally, but then there will be 5 MDA forms, 1 for each IU, as well as 5 supply chain forms, 1 for each IU. So these ones are reported back into the DHIS2 system by our country MEL staff, or where possible by partners, ministry or implementing partners. Now, following the completion of the MDA, there might be a coverage evaluation survey planned within the 3 months after completion of the MDA. This will be reported through a separate contract, and again, the data will be entered by a country MEL. So here you see the sequence of events and how data is expected to be reported back from the start to the end of a contract completion.